Hi there. My name is Ryan Dickerson. I'm a medical student at Brody School of Medicine, class of 2025, and this is our embryonic video on the development of the digestive system. As always, our mission statement for Scrubs is that we are a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody, and we participate on a variety of subcommittees to work on resources that we wish we had been exposed to during our time in the course. So we hope these aid you in your learning during your time in gross anatomy and embryology. As always, a disclaimer, our resources are made as supplements and are no way replacements to the instruction by the Brody student faculty, so please use these resources as a supplement and not as a replacement tool. With that, let's go ahead and dive into some material. Okay, so in forming the digestive system, it's important that we're going to be developing all of the organs that are associated from the esophagus down through the anus for digestion. And because of this, it's going to be really important that we have a strong foundation in adult anatomy because there's a lot of rotation and movement with this particular organ system developing. And so really want to make sure, if you don't have this nail down the abdominal aorta. The abdominal aorta has three anterior components that come off. You have your celiac trunk, SMA, and IMA. And we're going to see that the different components of the developing digestive system are going to be broken down based on the vascular supply that they're associated, and that would be the celiac, SMA, and IMA. So really important that you have that differentiation down, as well as the different components that form the digestive system, all the way from the esophagus, through the stomach, duodenum, to the jejunum, ileum, into the cecum of the ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anus. Okay, we also need to have at least somewhat relative understanding of the different mental regions and mesenteric regions of the GI system, because we're going to see that these are going to be moving throughout development. So I think having that foundational understanding is going to be really important for this unit. So again, recall that we're starting at the layer of the trilamellar disc. So we have our ectoderm, we have our mesoderm that's invading, and we're going to have our endoderm. The primary focus for the majority of this video is going to be associated with this endoderm and the associated mesoderm that is surrounding it. So recall that when we have the trilamellar disc, we're going to have the notochord induction, and that's going to start to form our axis by which we're going to form our body walls, and we're going to start to form the more adult derivatives and start to form more fetal structures. So what I want to point out is this lateral plate mesoderm. So again, we're mesoderm here. We're between the ectoderm, mesoderm, endoderm. This lateral plate mesoderm is going to differentiate into two components. We're going to have the somatophore. So the somatophore is associated with the lateral plate mesoderm as well as the ectoderm, and that's going to form part of our body walls. The splanchnophore, however, which is the focus of this video, is going to be associated with the lateral plate mesoderm and then the underlying endoderm. So that's going to be your splanchnophore. So that's going to be primarily what's going to be forming your gut tube. Okay, so this is a review of previous video, but again, the intraembryonic colon and gut tube formation. Big things here, again, the somatophore and splanchnophore are forming, and then due to that, we're going to have the intraembryonic coelom forming, so that's coming around on the lateral edges. And these lateral walls are going to start to come together, and they're going to fuse in the midline, and that's going to close off our gut tube. So initially, this is just going to be a single tube that's going to be running up from our oral cavity down to where our eventual anus is going to be. But it's, again, being partitioned off because of the closing in of these lateral walls. Okay. Really quickly, now that we've formed our gut tube, so again, a single tube that's going from the oral cavity running down, so it's centered in the middle of the developing embryo. This gut tube we don't want to have floating around in our abdomen, so we're going to anchor this down to our posterior abdominal wall as well as our anterior abdominal wall, and we're going to do that through the mesentery. So the mesentery is a continuous fold of tissue that connects the intestines and other digestive organs to the abdominal wall, keeping them in place, composed of two layers of the peritoneum that are folded over on one another. And what you will see that's important here is this is going to be where the different vessels that are going to supply the organs of the abdomen are going to be located. So the vessels run primarily through the mesentery to get to the gut tube. So the dorsal mesentery is going to connect the gut tube to the posterior wall, and in the region of the foregut, which we'll discuss briefly in a moment, we're going to have the ventral mesentery, and that's going to connect the gut tube to the anterior wall. Okay, so we formed this gut tube going from our oral cavity to our ventral anal region. What we need now is, now that we have the head folds forming and the tail fold forming, we're going to start to section off this gut tube. So the region that's associated with the head fold, or is incorporated by the head fold, is going to be the foregut. And we're going to see the embryonic derivatives of the foregut in a moment. But that's really taking you from the esophagus to the proximal duodenum. The midgut, which is going to take you from the proximal duodenum through the rest of the small intestine and the majority of the large intestine, and then the hindgut, which is going to take you from the last part of the transverse colon through the superior part of the anus. So hindgut is being incorporated with the tail fold here. So foregut with the head fold, midgut being wrapped up by the lateral body walls, and then the hindgut being incorporated by the tail fold. Okay, so we're going to break these down in those three regions and go from there. So we're going to start with the foregut. So the foregut is giving rise to all of the digestive system that is proximal to the second part of the duodenum. So that's going to include the esophagus, the stomach, and then the first part of the duodenum. We're also going to be, this is the component that's going to be deriving all of our accessory digestive organs. So this is going to be our gallbladder, our biliary tree, our liver, as well as our pancreas, and then not shown in this image, our spleen. Okay, so really important to pair each one of these major regions, the foregut, midgut, and the hindgut, with different vessels. So for the foregut, we're going to compare that with the celiac trunk. So if you understand your adult anatomy, what you'll see is all of the vessels of the celiac trunk are going to supply derivatives of the foregut. So you know, if you know what organs the celiac trunk is supplying, then you already know the different derivatives of the foregut. So again, foregut being incorporated by the head fold, blood supply celiac trunk, and then this is going to give rise to the esophagus, stomach, proximal part of the duodenum. So that proximal part is the superior part. Then the second part of the duodenum is known as the descending region. Third region is transverse, coming across, and then that fourth region is that ascending component. So it's making this C shape. All right, so for the foregut, we're only supplying that proximal region before it starts to descend. All right, we also have our liver, biliary tracts, gallbladder, and pancreas. We're going to go a little bit more into detail about how each one of these form. So we're going to start with the stomach development. So again, remember that in the region of the foregut, we have a dorsal mesentery and a ventral mesentery. Dorsal mesentery is attaching the stomach to the posterior wall. Ventral mesentery is attaching the gut tube to the anterior wall. And so during development, you have differential growth. So the posterior region of the developing stomach is going to grow faster than the anterior region, and that's going to cause the stomach to start to pouch out. Okay, so it's starting to pouch out here, and what we're going to see is this is going to eventually form our greater curvature of the stomach because of this differential growth, and then here we're going to have the lesser curvature starting to form. You can see that continuing to occur. The other thing that happens is the stomach is going to rotate around the longitudinal axis, and it's going to rotate 90 degrees clockwise. So that means over here, initially we have the patient's right side of the stomach, left side of the stomach over here, right side of the stomach over here in development. And then what's going to happen when we have that clockwise rotation, what started out on the left side is going to rotate and move anteriorly. So that's going to form the anterior wall of the stomach in the adult. And then what started out on the patient's right is going to rotate towards the back, and that's going to form the posterior wall, which we can't see here, but going posteriorly. So one thing that's important to know is that the vagus nerves are the cranial nerve that's supplying the majority of the parasympathetic down into the upper digestive system. So you know that the vagus nerves come down on the right and left sides, and as they get into the region of the esophagus, in the adult, you start to see them transition from right and left vagus nerves to anterior and posterior vagal trunks. And the reason that happens is because over here on the left, this left vagus nerve, in development, was coming down on the left side of the stomach, but when the stomach rotates, it then brings it towards the front. So that left vagus nerve becomes the anterior vagal trunk. And that right vagus nerve that was initially sitting on the right side of the stomach, when the stomach rotated, it got pushed to the back, and so it's going to become the posterior vagal trunk. So here's a posterior view here showing that. So right vagus nerve going down and forming that posterior vagal trunk. Okay, so now that we've talked about the stomach development and the different orientations of the vagus nerves as they go through the diaphragm, we now need to look at the liver and gallbladder development. So the liver and gallbladder are going to develop off of the proximal region of the duodenum, and it's going to be a little protrusion that occurs in the region of the ventral duodenum. The liver bud is going to be superior, and then the gallbladder is going to derive inferiorly. So you can start to see this occurring, development is happening. The liver is going to push up against the diaphragm, or the developing diaphragm. And in an adult, we recognize that the liver is positioned just under the right hemidiaphragm. And one of the components that derives the diaphragm, which is drawn as this line here, is going to be the septum transversum. So think back to the body cavity separation. Remember, the septum transversum is helping derive components to the diaphragm. Because of this close association, the septum transversum is also going to contribute some specialized cells to the liver. These are going to be the Kupffer cells and different hematopoietic cells. So Kupffer cells are pretty much similar, analogous to macrophages of the liver. So that's going to be the septum transversum contributing to these specialized cells. The majority of the liver, however, is made up of hepatocytes. So hepatos standing for liver, cyte cells, so cells of the liver. And this is derived from the endoderm that is coming from this ventral region of the duodenum, which is supplied by the foregut. Okay, so that's how our liver is developing. Again, our gallbladder is developing just underneath. So as the liver is developing, we're going to have connections from the liver to the duodenum. This is going to be our hepatic ducts. So going from liver to duodenum, hepatic ducts. Then from our gallbladder to our duodenum, this is my cystic duct. Those are going to fuse together. And when they fuse together, this is going to be referred to as my common hepatic duct. Or sorry, common bile duct. So you have your common bile duct once you have fusion of the cystic duct and the hepatic ducts. Okay, that common bile duct initially was coming out ventrally, because again, remember, these are ventral protrusions of the proximal duodenum. But because of the rotation that we already saw of the foregut, it's going to shift this connection posteriorly. So here you see the common bile duct being shifted posteriorly to enter into the duodenum, and this is the orientation that we expect to see in the adult. Now we also see the pancreas being derived here. We're going to talk about that in more detail on an additional slide. Okay, so with our pancreas development, unlike the liver and the gallbladder, this is not just a ventral growth. We have both a dorsal and a ventral pancreatic bud that is going to form. So with our dorsal pancreatic bud, this is forming posteriorly. This is going to give rise to the majority of the pancreas. So it's going to give rise to the tail, the body, and the superior region of the head of the pancreas. And it's also going to give rise to the accessory pancreatic duct if it does not degrade. We'll talk about this in a moment. And then we're going to have the ventral pancreatic bud, which is forming the more inferior regions of the pancreas, so the inferior head of the pancreas as well as the uncinate process. And it's going to be the component that's going to contribute to the main pancreatic duct. So the reason for this is because, remember that, so here's our ventral pancreatic bud. And the pancreatic duct normally will it'll join with the common bile duct before the common bile duct dumps into the duodenum. Okay, so because the ventral region is also supplying the biliary tree, it makes sense that the ventral bud that's connected to the biliary tree is also going to will eventually give rise to the main pancreatic duct, because that's going to allow communication with the biliary tree before you enter into the duodenum. Okay, so the ventral bud will start off anteriorly, so in ventral, dorsal starting off in the back. But when we have rotation of the stomach, this ventral bud is going to rotate posteriorly, and it's going to be wedged just underneath the dorsal bud, and these are going to fuse together, and this is where you're going to get your inferior head and your uncinate process of the pancreas. And then that accessory pancreatic duct that was developing from the dorsal pancreatic bud should fuse with the main pancreatic duct, and that'll give you just one pancreatic duct dumping again to the common bile duct to get into the second part, or the descending part of the duodenum. Okay, one thing I want to point out is that because we have that dorsal and ventral mesentery, there's a couple of specific things that are going to occur as we have rotation. So one thing I want to point out, within this dorsal mesentery, we're going to have the development of another organ that is, it's not one of the digestive organs, but it's still located in the abdomen. This is going to be our spleen. So the spleen is developed because mesoderm is going to invade this dorsal mesentery just behind the stomach, so posterior to the stomach in development. And you can start to see that happening here. And then rotation of the stomach is going to bring the dorsal mesentery towards the left, bring the ventral mesentery towards the right. And we know that the spleen sits on the posterior left aspect of the abdomen, and that's what we're seeing here. So the spleen starting in that dorsal mesentery, getting pushed posteriorly. All right. The ventral region again is going to shift to the left, or sorry, shift to the right, and more posteriorly. And this is initially where the liver is developing. It is developing inside of that ventral mesentery, but as it gets shifted to the right and posteriorly, it's going to take up its final position, which is going to be back here, just lateral to the stomach, okay, and just underneath that hemidiaphragm. So with that in mind, I wanted to break up some of the different derivatives of the ventral and dorsal mesentery based on the understanding that the spleen is going to develop in between the posterior wall and the stomach, and the liver is developing in between the anterior wall and the stomach as well. So between the posterior wall and the spleen, so this is part of your dorsal mesentery, you're going to develop the splenorenal ligament. Because remember that the kidney, or referred to as renal here, is going to be retroperitoneal. So you have splenorenal ligament. Okay. Then in between the greater curvature of the stomach, which is on the left side in development, and the spleen, this is where we're going to have the gastrocolic ligament, the gastrosplenic ligament, and the gastrophrenic ligament. So these are all components of your greater omentum. The lesser curvature of the stomach, which again is going to be located on the right in adults, connecting to the liver, we're going to have our hepatogastric ligaments and hepatoduodenal ligaments. And then connecting the liver to the anterior wall of the abdomen, this is going to be our falciform ligament. And remember, at the base of the falciform, you're going to have the ligamentum teres in adults, and that's the obliterated umbilical vein. Okay, so that takes us through the foregut. Next up, we have the midgut. The midgut is giving rise to all the structures distal to the proximal duodenum up to the region of the splenic flexure. So that means we're developing the rest of the duodenum, so the second through the fourth components, the jejunum and ileum, so most of the small bowel. Then we're going to derive the cecum, the appendix. We're going to come up the ascending colon, the transverse colon, and it's going to do the proximal 2/3 of the transverse colon. Okay, so those are the derivatives of the midgut. The artery that's going to be associated with the midgut is going to be our superior mesenteric artery. So if you know the distribution of the superior mesenteric artery, you know that all of the structures that receive blood by the superior mesenteric artery are derived from the midgut. So we're going to talk a little bit about how these structures are going to rearrange during development from a single tube into this convoluted mess we see in adults. Okay, so this is probably the most complicated component of the midgut development, and this is going to be protrusion and rotation of the midgut. So the first thing that is going to happen is we're going to have what we call physiologic herniation of the midgut through the region of the umbilical cord. And this is going to be because we have growth of the abdominal components, so we need some additional space. So it's going to protrude through the region of the umbilical cord. And so that's going to, we'll say that is happening in the region of this cross section. So you have protrusion out through the umbilical cord, and here we have the SMA, which is coming out and supplying the regions of the midgut, or the developing midgut. And initially, you're going to have a cranial portion. So this is going to be located superiorly, and you're going to have a caudal portion located inferiorly towards the rear of the developing embryo. Okay, next, we're going to have our first 90-degree rotation. So in this 90-degree rotation, we're rotating that cranial pole towards the right. So it's coming down towards the right. That caudal pole is coming up and towards the left. Okay, so going down towards the right, up towards the left. So that's the first 90-degree rotation that happens along the axis of the superior mesenteric artery. So what that ends up causing is the caudal limb to now be located on the patient's left. All right. So here is where it often confuses people. The second thing that has happened, towards the end, the last thing that's going to happen is we're going to have retraction of the midgut back into the abdominal wall. And when it does that, it's going to continue to rotate 180 degrees. So we take this caudal pole that's already been rotated 90 degrees, and it's going to rotate 180 degrees all the way around over top of that cranial pole. And so that ends up causing this developing small intestine to be located posteriorly, and the developing colon to be located coming across, and that's going to be our transverse colon. So in total, we're going to have 90-degree rotation plus another 180-degree rotation, which is going to summate to the midgut rotating 270 degrees during development. Okay, next up we have the hindgut. So the hindgut is giving rise to all of the structures from the end of the midgut all the way to the superior anal canal, and so that's going to be the distal third of the transverse colon, the descending colon, sigmoid colon, rectum, and superior anal canal, specifically the superior 2/3, and we're going to talk about why that is in just a moment. The associated vessel here is going to be our inferior mesenteric artery, and again, this is being incorporated by the tail fold. So the most complicated component of hindgut development comes with the cloacal separation. So the cloaca is the terminal dilation of the hindgut. So here we have the hindgut coming down, and at the inferior pole, it's going to have a large dilation. That dilation is called the cloaca. Of note, the skin just distal to the cloaca is going to be called the proctodeum. So the proctodeum is then going to invaginate, and this invaginated ectoderm is going to eventually form that inferior component of the anal canal. So here you can see here the proctodeum invaginating, going in towards the eventual anal canal. But before the ectoderm and the endoderm can actually communicate with each other, there is what we call the cloacal membrane, which is a membrane that separates the two. And this is formed by ectoderm from the proctodeum as well as endoderm from the hindgut. So there's a membrane that's separating the hindgut and the external environment, and that's via the cloacal membrane. So interestingly, we'll talk more about this later, but the cloaca is going to give derived components both of the urinary system and of the digestive system. So we need to separate, because we know in adults that those two things are different, we need to separate the cloaca into the urogenital regions and the anal and rectal regions. So what's going to happen is we're going to have the urorectal septum is going to start to develop, and the urorectal septum, you can see here, is formed by mesoderm. It's going to grow inferiorly, and it's eventually going to fuse with that cloacal membrane. So here it is, urorectal septum coming down, getting closer to the cloacal membrane, and eventually it's going to fuse with that cloacal membrane, and it's going to split the cloacal membrane into two different membranes. The one in the front is your urogenital membrane, and the one in the back is your anal membrane. Okay, so eventually, as you continue to develop, that anal membrane is going to rupture, and that is going to allow connection between the superior and inferior anal canals. So that superior anal canal being derived by components of the hindgut, that inferior third of the anal canal being derived by regions of the proctodeum, which is ectoderm. Okay, the junction of those two components, so going from endoderm to ectoderm derived components, that is going to be known as the pectinate line. So you'll review this more in your anatomy specific courses, but I want to point out here's your pectinate line. And the reason that this is so important for us to understand the different embryonic developments that are associated is because the hindgut, as we said, has the inferior mesenteric artery supplying it. So all of the region, or the entire region above the pectinate line, is going to have very specific arterial and nervous supply, whereas the region below the pectinate line is going to have a different arterial and nerve supply, as well as lymphatics and venous drainage, and that is because it's derived from the ectoderm as opposed to the hindgut endoderm. Okay, so you'll review this more in anatomy, but I just want to point out this is why it's so important for us to understand that everything above the pectinate line is derived from the hindgut, everything inferior to the pectinate line is derived from that surface endoderm. Okay, so here's a summary of our embryonic derivatives of the gut tubes. So you have your foregut, which is associated with the celiac trunk and all of the organs that are getting blood supply from the celiac trunk. So this is going to be the distal esophagus, the stomach, proximal duodenum, specifically that the first part of the duodenum, which is the superior region, the liver, biliary system, gallbladder, and pancreas. The midgut is associated with the superior mesenteric artery. It's going from the second part of the duodenum. So the second part is descending component. Then we're going to have the transverse and then ascending. So this is second, third, and fourth components of the duodenum. Going to the jejunum, the ileum, cecum, and appendix. We have the ascending colon and transverse colon, specifically at proximal 2/3, all getting blood supply from the superior mesenteric artery. all derived from the midgut. And remember that midgut had the 270-degree total rotation during development. And lastly, we have the hindgut, incorporated with the head fold or the tail folds, supplied by the inferior mesenteric artery, and that's going to take you from the distal transverse colon, so that distal 1/3, through the descending colon to the sigmoid, rectum, and superior anal canal. Okay, here's a table that's just listing the different embryonic derivatives of the mesentery. So we talked about the region in the foregut, so that's going to give our falciform. The coronary ligaments are associated with the liver. The lesser omentum with the hepatoduodenal and hepatogastric ligaments. The dorsal mesentery, we talked about the greater omentum and some of these other components like the splenorenal ligament. But remember that the dorsal mesentery is attached all the way down through the developing gut tube, including the midgut and hindgut. So we're going to have components of the midgut and hindgut mesentery as well. So that's where we're getting the mesentery to the small intestine, the mesoappendix, transverse mesocolon, sigmoid mesocolon, and phrenocoelic ligament. All right, let's dive into some clinical anatomy. First thing I want to point out is that if the esophagus has any issues during development, two major things or common things occur. One will be esophageal stenosis. So this is where the esophagus has a stricture, so that's going to limit food coming down. This can be an issue with feeding, especially in the neonatal period. And then we also have more serious is going to be esophageal atresia. We talked about esophageal atresia when we talked about the respiratory development. So there's a bunch of different kinds of esophageal atresia. You can have esophageal atresia with a tracheoesophageal fistula, which means that you have a communication between the trachea and the esophagus, which can lead to some different sequelae. But big thing here is this is failure of the esophagus to canalize in a region, so it's an actual absence of esophagus in this communicating region. Next up, we have hypertrophic pyloric stenosis. So this doesn't present initially on birth. It's going to present around the 2nd to 7th week of life as you're feeding the infant. What happens is the pyloric muscle. So remember, the pylorus is the region that separates the end of the stomach, separating it from the duodenum. The pyloric muscle is going to become hypertrophic, meaning it's enlarging, and it's going to compress this region, and we're not going to be able to transmit the gastric contents past the pylorus. Okay, so this is due to hypertrophy of the pylorus causing stenosis, and because this is proximal to the region of the biliary tree, so the biliary tree again is going to be coming in the second region of duodenum, this is going to cause vomiting that is non-bilious vomiting. So it does not have bile in it because we're proximal to the biliary tree coming in. And because this is hypertrophic, you're filling the stomach up with fluids, not able to go anywhere. This is going to cause projectile vomiting. All right, so you have a descendant proximal segment. Because the pylorus is becoming hypertrophied, you can actually feel this on a lot of neonates, and it's going to feel, the classic sign is an olive sign. So it feels like a little olive underneath the skin, and what you're feeling there is the hypertrophic pylorus. And you diagnose this with an ultrasound or barium swallow, and it will show dilation proximally, hypertrophic pylorus, and then no, if you're doing a barium swallow, no contrast past the stenosis. Next up, we have duodenal atresia, and the way that you'll see duodenal atresia presented on many national tests is with a double bubble sign. So that's what we're seeing here. So this is an image of a child who has duodenal atresia, and so it's a relatively uncommon finding, but it is at higher risk with Down syndrome and prematurity. And because this is going to be usually happening in the distal duodenum, either past the second component to the third or fourth region of the duodenum, this is going to be bilious vomiting. So there's bile within the proximal components that allows bilious vomiting. And you have distension of everything proximal to the atresia. So that's going to be distension of the stomach and the proximal duodenum. So here on this x-ray, we see distension of the stomach. We have a stricture here, and then we have the distension of the proximal duodenum, and then there's no other bowel that we can see because it's got no air in it, because we don't have any way to communicate because it's atretic in this region. So the question is, why do we have two bubbles? What is causing this stricture between the stomach and the duodenum? And the answer there is this is the pyloric sphincter. So this isn't actually stenotic, but it's just the sphincter located here, which is allowing the first bubble in the stomach and then the second bubble in the proximal region of the duodenum. Then no air distally because we don't have a communication between this proximal region of duodenum and distal because it did not form. That is known as atresia. Next up, we have annular pancreas. So annular pancreas occurs when you have abnormal rotation or growth of that ventral pancreatic bud. So remember, the ventral pancreatic bud is initially coming off the anterior region of the duodenum. If it doesn't rotate posteriorly like it's supposed to form that uncinate process in the inferior region of the pancreas, or inferior pancreatic head, then it can actually constrict the proximal mid-duodenum. And so because this is often after the biliary tree has entered, you're going to get bile in the vomit, so we're going to call this bilious vomiting. Okay, so bilious vomiting coming up and out. Okay, so that's annular pancreas caused by abnormal rotation of the ventral pancreatic bud. Two presentations that are relatively similar that we need to be able to differentiate. This is going to be omphalocele and gastroschisis. So omphalocele specifically refers to failure of the bowel to be retracted during development. It is going to be surrounded in peritoneum, and it protrudes through the umbilicus, because this is the region where we had the bowel coming through with that physiologic herniation in development. So it happens through the umbilicus, covered in peritoneum, caused by failure of retraction of the bowel during development. Gastroschisis, however, is failure of the lateral wall to close and fuse at midline. Okay, so you can see here we are off the midline. We're not through the umbilicus. We're a little bit lateral, and this is not covered in peritoneum. So there's going to be the big differentiation points for omphalocele and gastroschisis. Okay. In rare cases, it's possible for that 270-degree rotation that we discussed to not occur, and we refer to that as malrotation. So that's failure of those 270-degree rotation in the midgut, and it can predispose individuals to volvulus because you have connections with the mesentery that aren't established like they are in a normal adult, and volvulus refers specifically to mechanical twisting of the bowel. So you can see an image of that here. So this is midgut volvulus. So you have twisting of the midgut around the cecum. And what that's going to cause is possible ischemia of the bowel that's being twisted, and that can lead to necrotic bowel. Okay, and this is because you're twisting around and you're disrupting the blood supply to that region of bowel. Okay, so malrotation, not having that 270-degree rotation of the midgut, that can predispose you to volvulus. And volvulus is the twisting of bowel around itself, and that can lead to disruption in the blood supply and eventual necrotic bowel. All right, last clinical presentation is congenital megacolon. So congenital megacolon is caused by failure of the neural crest cell migration to the distal colon. Neural crest cells are going to be supplying the parasympathetic components to the distal colon, and you can kind of see here, if you take a histologic sample of the distal colon, you should usually see underneath the muscularis mucosa, you'll have the mesenteric plexus. So you see that here. Then a little bit more closer to the serosa, you're going to have the Arbach plexus, so Meissner's plexus and the Arbach plexus. These are again derived by neural crest cells, but in congenital megacolon distally, you don't have the neural crest cell invasion, so you don't have these parasympathetic plexuses. So that means you're not able to get good peristalsis and contraction of the bowel, and because of that, this acts almost like a stricture, and you're going to have build-up proximally and dilation because you do have parasympathetics proximal, so it's going to be pushing stool distally, and eventually it's going to accumulate, and it's going to dilate and become really large. So this is congenital megacolon, one more time, caused by neural crest cell failure to migration. And that brings us to an end to this.